what is the right therapy. There's a lot of controversy, obviously, about TAVR versus SAVR, even nowadays through 4 and 5 year data, but also in the context of younger patients with bicuspids and more complex anatomy potentially.
Great. This is Aiden Raney with MurmurMD. We're really excited to have Matt Summers on today. He'll be talking about his approach to valve choice, valve therapy decisions. He is the program director of structural heart at Sentara Heart Valve Center. And Matt, take it away. Happy to have you on.
Happy to be a part of this. You and I had talked in the past about sort of how I approach valve therapy selection and how we make decisions here. And that's been a unique sort of experience from the time I came out of fellowship in 2019 until now. Where we're at with TAVR is quite a bit different than the first and second generations of TAVR, where our predecessors were really trying to get people through procedures and trying to get surgical type results, but really with high risk patients. And so I uniquely came out of training in 2019 from Cleveland Clinic, and it was just as low risk indications were coming out for both valves. And we had equipoise between the two valves up to that point. And we're able to make decisions about not just SAVR versus TAVR, but two different valve platforms that have unique characteristics. And so have some sort of content that we have developed, basically how, when I put pen to paper, how I think about valve selection in the context of whether it is SAVR versus TAVR, but really whether it is self-expanding valves versus balloon-expandable valves, and how over the past 5 years that has morphed into what we're currently doing right now, which I think is mostly centered on each individual patient, trying to provide individualized medicine within that realm of valve selection. So choosing the valve based on the patient's unique anatomy, choosing the valve based on the patient's unique clinical characteristics, and then also within the context of what we know currently about durability and valve performance. And so the title of this is our contemporary approach to valve therapy decisions, how we make programmatic strategies for valve selection, valve therapy disposition, and lifetime management. And so as I mentioned, I was fortunate to join a very, very high functioning, high volume center in coastal Virginia, Sentara Heart Hospital, where we will evaluate 1,000 patients a year with AS, do right around 500 TAVRs, and that predated me, and around 150 MitraClips, TriClips a year as well. And as I mentioned, in 2010 to 2020, the first two generations of TAVR, really our goals were to try to expedite patients' therapy. These patients were pretty far down the line in AS, didn't have other options, weren't surgical candidates, and we were trying to minimize the risks of those procedures that we were really first and second generation within the context of their specific risks. And patients will ask, and they still ask, will this be okay until I'm fixed? And is it going to make me feel better? But will I survive the surgery or have any other problems? And that's really the context in which we approached patients the first 10 years of TAVR. I came out of training in 2019, right as we were really morphing into this next generation of TAVR, which is, well, it's a given that they're going to make it through the procedure. It's a given that it's going to fix it, that it's at least non-inferior to surgery through the first two years or so. But how are we going to get a surgical type result as far as durability, and what happens when it does wear down? How are we going to reapproach patients? And so patients, as you know, will start asking those questions and have asked those questions. It's dominated the conversations in the past 5 years is, well, how long is this going to last?
Right.
Do I have to stay overnight?
Yeah.
Can I go home the same day?
Right.
When can I start exercising again? And, well, how long is this going to last?
Yeah.
And so the conversation has changed completely, I think, in our time.
I totally agree. I mean, I started my fellowship in 2014, and we were in some of the original high-risk trials, and, it was a much dicier proposition, and, you just have to get the patient through it. But now it's really progressed, and, expect to have very good results. And I agree, it's a much different conversation.
So when I think about, there's a million topics, sessions on lifetime management at all of our conferences. But when I think about how we're putting together these decisions now at a high volume center based on what we have available to us as evidence. I'm trying to make a therapy decision at the right time, and that's where we've started to incorporate these ideas of asymptomatic patients and moderate AS. We've participated in those trials and now have the indication for AS, asymptomatic AS patients. What is the right therapy? There's a lot of controversy, obviously, about TAVR versus SAVR, even nowadays through 4 and 5 year data, but also in the context of younger patients with bicuspids and more complex anatomy potentially, and the ability to take care of them through their whole life as a consequence of that first decision. And then what valve is going to perform the best? It's not just SAVR valves versus TAVR valves, but which type of valves are potentially going to last longer or have a more durable result in the context of those patients' specific individual characteristics. And then really leaving doors open, I think, is the way that I look at most of the clinical decisions we make is what is the penalty for being wrong? If I choose X valve versus Y valve or SAVR versus TAVR, what may happen to that patient if all of the information I'm using arrives at a decision where it wasn't the right answer? And initially that was a lot of fears about coronary reaccess and redo TAVR feasibility. And as we've accumulated more data, more experience, I think a lot of those concerns have been alleviated in a lot of regards. And so when I think about these things, as I mentioned, I know there's a lot of information about lifetime management. And when I came out of training, it was still the case that 20% of patients outlived their TAVR. So it was a small percentage of people. And the median time until we were asked, you and I are asked to do a valve-in-valve TAVR is 8 years. You know, the average time of a surgical prosthesis is around 13 years. A lot of that data, as you know, was based on the fact that patients didn't get reoperated on if they were over 75 or 80 years old. And so that, you know, their reoperative or redo procedure was never captured as sort of an endpoint. And so it's kind of a muddy picture of how many valves a patient will need, how long will tissue valves last in general. And then now we're getting data on TAVR, how long they will last. But when I'm making a decision, and we make decisions in Valve Conference, which is every Monday, we'll review 25 to 30 patients, all with core data that we're trying to capture in order to make that decision, where we have equipoise between two valve systems, and we're trying to make individualized therapy decisions. When I put pen to paper, I think of 16 different things that we use to make these decisions between the two valves. What was unique for me is I came out of training like most fellows at a big academic place that most of my experience was balloon-expandable valves. It's 92% S3 of the 250 or so valves I was fortunate to do with the incredible folks there. And then I joined a large group where I could pick both valves now. And I didn't just see the patients during the procedure. I saw them at 30 days. I had patients have access to their echo report before you see them at 30 days. We have to have the discussions about gradients afterwards. And then I see them through the whole first year. And so I joined a group that had a little bit more of an even distribution of BEV versus SEV. And these sort of ideas of how I was trying to decide all of a sudden of how to pick one valve versus the other came up. And in 2019, we certainly felt a certain kind of way about hemodynamics. We were reluctant to put in 20 S3s because of patient prosthesis mismatch. And when we knew that 19 millimeter surgical valves, we cringed when we saw them. And then, so those tended to favor already supraannular self-expanding valves. Same thing with hostile annular anatomy. We would either subtract volume, I know that's common practice still, or we would decide about a self-expanding valve. Small annulus is this FORSMART trial. We still, it's plus or minus whether we would use a better performing hemodynamic valve at least. Prior pacemakers would usually push us or make us think a little bit more about evolutes, just because the pacemaker rates in Sertavi were 20-25%. Durability was still in question. We didn't have 4 and 5 year data. Iliofemoral issues, E-sheath was a little bit better, a little bit easier to navigate. And then a lot of the rest of the things really favored a SAPIEN first approach. TAV and TAV feasibility, a lower frame valve, worried about explantability and coronary access. Certainly the older systems for much more difficult to navigate a horizontal aorta. We wouldn't be able to discharge patients the next day because we were watching conduction abnormalities. And then narrow and shallow sinuses with concern for sinus sequestration gave us a lot of pause with using self-expanding valves, especially superannular self-expanding valves. And when I put things pen to paper again of how we think about it now with those same 16 or so factors that we were using to make decisions, right as I was coming out to a larger group, we've gotten a lot of more data about durability and hemodynamics, BVD rates, things of that sort. We have the capacity now for commissural alignment, which I think has allayed a lot of the concerns about coronary access and coronary occlusion risk during procedures. Our surgeons here locally, as someone who's never operated or explanted on one of these patients, our surgeons will say that it's actually quite a bit easier to take out a self-expanding valve because of the nitinol features of it. And honestly, a lot of the concerns that we had, the differentiators about conduction and pacing and length of stays, have went away now that we have cusp overlap technique and single-digit pacemaker rates and lower pacemaker rates. So now, just kind of naturally, without an intent really towards just anything other than looking at these 16 different factors and trying to make a decision for each individual patient, because of those things, hemodynamics, commissural alignment, and cusp overlap lower pacemaker rates, we've now switched to where we're hovering right at about 85% self-expanding valves. And so just in my 6 years of training, it's really flipped on its head, 6 years since training, it's really flipped on its head as far as how I think about these and how we're making valve selections.
That's great. I mean, I think my experience has been a little bit the opposite, started with more self-expanding and kind of ran into issues and went more, predominantly balloon-expandable. But yeah, I'd love to hear more.
And so I know this data is not new, but what has, if I take the next step and say what has really guided that outside of just anecdotes and local experience, what has guided sort of those philosophies or those decisions towards picking one valve versus the other? And this is, of course, very, very controversial. Just at New York Valves, there's entire sessions on this with leaders in our field debating. And so I know that there's two sides to every coin, and this is one of them. But when I look at the data and I see hemodynamics, first of all, the first thing to note is that we've made the surgical experience much better with root enlargements. We've known for a while that all TAVR platforms really have better hemodynamics. And again, that's compared to rates of surgery where we didn't have very high rates of root enlargement. But in general, both 5-year Evolute data and now we have Notion 10-year data show that the hemodynamics, the valve performance with an eye towards hemodynamics tends to be better with TAVR versus SAVR. And then, of course, the SMART trial is something that was big that came out during my transition out of fellowship and has guided some of these decisions. We know that hemodynamic performance is consistently a bit better for self-expanding valves than balloon-expandable valves. And then what does that mean towards outcomes? What does that mean towards SVD rates? We know that by a variety of different factors and measurements, we tend to get better hemodynamics with self-expanding valves, particularly superannular self-expanding valves. And this is really borne out in the SMART trial for smaller annulus patients, of course, where we didn't see any difference in hard outcomes, which there's a lot of debate about that, but that we wouldn't really expect to see at 2 years. But by our current definitions of BVD through 2 years, we're seeing significant differences in the rates of valve performance and valve dysfunction at 2 years. And so when I look at this data as someone who's comfortable doing both valves, I see what I've seen in clinical practice, which is patients coming back at 30 days and 1 year with gradients that are elevated in one valve platform that I'm then having to make decisions about. At 2 years, I'm not having to send them to my surgical colleagues to get surgery. They're not having strokes. They're not, coming into the hospital with heart failure necessarily yet. But we are making decisions about, does this patient have halt? Do they need a CT scan? Do I see them at 3 months, at 6 months with another echo? Am I putting them on empiric anticoagulation because their gradients are 20 to 25, those kind of things? And that really has matched what I think was seen in this trial, is that we have to make a lot of decisions about these patients in the short term. But if we just take a purist stance on what our definitions of BVD are, I know that if I pick for small annuluses less than 430, if I pick 3 Sapiens, 2.8 Sapiens, I've at least met that definition at 2 years. for SV or for BVD in the SAPIEN group. And so there obviously there's caveats to this, and it goes outside of this specific talk. But when you dig down even further, the 430 is just the number, but for 20 and 23 S3s, really you see that absolute risk reduction in BVD rates all the way up to 430. And so as a consequence, I don't know where that ends. And I know that's the next phase of this is, can we see PPM or can we see valve degeneration and valve dysfunction in larger annuluses? And that's, I think, what we're going to find out over the next 5 to 10 years. But what was important here is that S3 was a predictor of that BVD in small annuluses, and that matched what I saw clinically in practice. The flip side to that, and a reasonable counterpoint to that, is that those are just definitions. Our definitions change. You can interpret the NOTION trial data through two different lenses of definitions of valve performance and BVD rates. And so those are reasonable counterpoints, that they're not yet associated with hard outcomes or differences. And that's certainly true. We wouldn't, again, expect to see, I'm not seeing a lot of these clinical hard outcomes at 2 years after a valve, but I am seeing them in the 5 to 8 year time frame. And that's really where I think these next 5 years are going to be so important with us understanding the data and valve performance and valve degeneration. A lot of these decisions about redo TAVR versus explant that has a high risk of complication. Both of them are quite complex. That's where I think some of these things will be borne out. We do have some data that shows that we have worse 5-year outcomes, regardless of the modality, SAVR or TAVR, with this definition of BVD across all different types of outcomes and across surgery and evolute. And so there is some data that's accumulating with regards to this definition of BVD being associated with the more hard outcomes. But I think the next 5 years are going to be incredibly important for us making these decisions. And again, I think if we're being guided by the data, these next 5 years will give us quite a bit of information about how we make these decisions going forward. But this is through current data with NOTION trial, SMART trial data, the 4 and 5 year data. Where we settle on things is that we're much more comfortable making a lot of these decisions towards a hemodynamic eye. If all things are created equal and pacemaker rates are going down, we're seeing that a lot of it defaults to which valve do we think is going to perform better hemodynamically, and we make the decision based on that.
Yeah, no, and I think that's, I agree. I think the hard data is something that will be interesting to see, and we don't really have that now. But clearly, the numbers are different. So
when I think about these things as well, it's a lot of it is the penalty for being wrong. Just like I mentioned, the explant is a complicated procedure. Just surgeries on patients with prior TAVR period is a much more complex surgery and has its own risks. And I think as we're making the decisions about explant versus redo, that is where some of this data is going to be accumulated as far as the risks of those procedures and the risks or the penalty of the first decision we made. A lot of that feasibility for redo really depends on commissural alignment, which has been addressed by the most current version of the evolute valve. But we've also had some of these concerns about leaflet overhang and neoskirt height and creating a tube graft that causes sinus sequestration. And so, this is a case that highlights sort of when these do come back, which they are coming back because we've had a decent volume of balloon self-expanding valves. These BEV and SEVs are very complex to even model for and to make decisions for. The app that's been developed is at least 2 or 3 times more complex than the original valve and valve app as far as guiding you through CT measurements and planning, particularly for BEV and SEV. And so. Yep. What we've done ultimately is taken this entire milieu of data, the ability to choose either valve platform, now a third valve platform, and sort of these different parameters that we historically make decisions by and how we're making them now, to arrive at basically one core slide that we make in our valve conference. We'll review 20 or 25 of these each week, but it tries to distill everything down to those key elements that we're making decisions on. And ultimately what that ends up being is a combination of annular anatomy and annular anatomy risk towards specific TAVR type complications, and then hemodynamics. And then we're commonly making the decisions based on those two parameters. And obviously, when you look at this slide in particular, when we're making decisions about valve and valve, and we're measuring BTCs and BTSTJs, it's incredibly not just labor intensive, but it also you can get several different measures every time you measure. We'll all sort of measure things together and compare notes. And there's a wide variation in some of these numbers. And then the thresholds to intervene and do leaflet modification have changed over time. And ultimately, we're still just taking a CT scan and drawing circles over top of them.
Yeah.
And as I'm trying to make all of these decisions for 500 patients a year, that just didn't feel good enough for me to make a very important decision where there are some blossoming ideas about differences in valve performance, and I'm making those decisions between those two valves. And so that's really where our center has, I think, taken it to the next level, where we've tried to incorporate the most advanced pre-procedural modeling and predictive modeling to make some of these decisions, to try to understand annular anatomy risk towards annular rupture, and try to understand not just feasibility of redo TAVR with respects to coronary reengagement and coronary alignment, but also understand sort of the importance of having that door open from a standpoint of the initial valve leading to capabilities or possibilities at the second valve. And that's really where we've incorporated DASI. And so this is a standard patient. This is how we're doing things now, which is we're taking, a 72-year-old male bicuspid, and he's got two options, now three options. And that can be a 26S3 or 34 Evolute. And we're using really what amounts to be the best and most capable form of not just 3D printing or virtual 3D printing, which is still static simulation, static images on top of anatomy. It's actually looking at stent expansion and tissue deformation. And then on top of that, with large volumes of data and pre and post, not just CTs, but outcome measures, AI's allowed us to dig down into the weeds a little bit further and find better predictive measures of things like coronary occlusion, paravalvular leak, and annular rupture risk. And so what we're doing right now is taking Piedmont's lead on this, is doing this in all of the patients that we have any of these concerns for, either younger patients that we want to make sure we have feasibility of a second valve, or patients that have hostile annular anatomy, high calcium scores, patients that have valve and valve and a redo TAVR that have coronary occlusion risks. We used DASI for the past 2 years in those higher risk sort of unique scenarios to make the decisions about the valve therapy dependent on what those variables are, and also a better understanding than just a three-dimensional reconstruction, but a basically multi-plane view of circles drawn on top of CT scans. This was very reassuring to us when we started adopting it uniformly towards our decisions of self-expanding valves, because it showed that with commissural alignment, by and large, we maintain our coronary reaccess rates, and it allowed us to more specifically define which patients benefit the most from leaflet modification, which patients were at the highest risk for leaflet or for coronary occlusion and sinus sequestration.
So a couple of questions. So what percentage of people are using DASI? I tend to use it if something looks high risk, send it off to them. And still putting kind of circles in 3-Mencio myself. What percentage are you using them for now?
It's morphed over time. We're still using it in the highest risk patients, much like you are. And I've used the protocols that were developed at Piedmont, so valve and valves, patients under 65, high calcium scores, and basically to look at PVL risk, look at annular rupture risk, and look at coronary occlusion risk. We're still in the final stages. It's in the next month. It will be uniformly for every single patient, all three valves modeled, and decisions made based on that modeling.
Yep. And then I understand they're doing some work on valve and valve with DASI. I haven't seen that. Have you been part of that?
Yeah. So the valve and valve model, Yeah, with the valve, that's really been the biggest clinical impact. In 2023, we did 27 leaflet modification cases for a denominator of cases, which is really around 47 to 50 redo or valve-in-valve TAVRs. So it's almost more than half of the cases that were quote unquote high risk for coronary occlusion. We were using basilica in, and then just incorporating DASI, it went down to 7.
That's amazing.
So a 75% reduction without any coronary occlusion. We haven't had an annular rupture since January of 2023. I think, those are low risk numbers. And so the number to realize a difference is obviously much higher. And we understand that. But just going into a procedure with eyes a little bit more widely open as far as these individual risks and what may happen. When you have two very, very, very good valves and you can sort of split hairs this way and try to go into a procedure with that added information that's much more precise than what we previously have been doing, we've found incredible value because now we can use things like shortcut or dedicated devices that are somewhat costly in the patients that absolutely need them the most.
Sure. Yeah, I think that's, that's pretty impressive. Like, you think about all those cases you did that you didn't have to do. It's not easy, right? So,
and the risks that come with them and the complications, and absolutely.
My other question though was in terms of how you place the valve, thinking about the next valve down the road. Do you see the AI having a role in that? Where we've got two platforms, you can put this one a little lower, we can use this size. That's where I also see a big help with some of these models.
Yeah, and I think this is what's coming. This is their precision TAVR, and this isn't meant to be, an advertisement for DASI in any way, shape, or form. But this is what I see is how we're going to be making these decisions next. Is incorporating this, at least at a bare minimum, it's better visualization of exactly what will happen. There's within a 10% margin of error on the stent expansion, which they got FDA approval for. And so within a 10% degree of certainty, we can understand what the stent's going to do in very specific anatomy. And I think that's where things are powerful. As you can see here, you can pick any of the 3 valve platforms. They showed an accurate there, which we won't be picking from, but we can change the implant depth. And what's more importantly in this is we can see where there's potential issues. You can see the stretch and strain on the annulus. This prompts us to implant sapiens very high when we're worried about annular or LVOT calcium. So you can sort of see the consequences of what happens as you deploy the valve at different levels. But more importantly, they show us putting in that second valve here and what that would do in 10 to 15 years. And so this is the way I see the next 5 years panning out for us in the field. Is really we're going to be making decisions about S3 and S3, or first valve is evolute, second valve is a BEV at node 5. We're going to implant our initial valve at 4 millimeters. The membrane septum is at 6 because that's going to allow us for a node 5 or 6 implant in 15 years. I see us going more from us having 10 people measure VTCs. And just trying to get out of a procedure and get some durability to now we're planning true lifetime management with a level of sophistication that helps us at least visualize in this fashion how we're going to do that next procedure if they outlive the first one.
Yeah, and I spent a lot of time, trying to simulate this on my own with 3D software currently available. And this is just, you just can't, there's limitations, right? This is really, I think it'll be a game changer. So this is great. I've heard they've been doing some work. I haven't seen it yet, but it looks pretty impressive.
I think we obviously need the data to guide these decisions as well, just using this as another tool. But with experience, what we've seen, again, anecdotes, not necessarily data, we've seen that this has laid a lot of our concerns about coronary access and valve or redo valve feasibility. And it's allowed us to at least be more precise from a visualization standpoint. However you feel about AI variables and the test characteristics of these, it's allowed us to be more precise going into procedures, much more than we would expect. Airplanes are designed for the last 20 years with more sophistication than a lot of what we're going into TAVR with when we're trying to do a procedure, a very complex procedure that can be life and death on people. I always looked at how planes were designed and how Formula One cars were updated week to week to week based on really, really sophisticated modeling, and that we weren't doing that in cardiology and weren't doing that in structural heart was incredible to me. And so I'm fortunate that these kind of tools are available now, and as they mature, I think we are going to get to that point where we could go into these cases in a much more sophisticated fashion.
And I think they'll get better. I did have a case where there actually was no evaluated for coronary heights. There was no LVOT calcium, but it ended up having a rupture, and it was the sinus itself and a big chunk of calcium that was shaped like a dagger. And and I think as these models, the more they see, the better they get. So, but yeah, I think for making these kind of decisions, this will be kind of a game changer.